Welcome. My name is Tegan Blaine. I'm the Senior Climate Change Manager or Senior Climate Change Advisor for the Bureau of Africa at USAID. And I am pleased to be able to introduce our speaker for the day. But first, I would like to say a few words about this seminar series. Many of you may know this, but just in case there are some new people here, this is the Adaptation Community Meeting, and it happens on a monthly basis, hosted by Chemonics under the ATLAS project, which is a USAID-funded project for adaptation thought leadership and assessments. Thank you. It occurs on the third Thursday of every month, and if you are interested in signing up to receive information about the ACM, you can do this through the sign-up sheets in the back of the room, and you can also go on to climatelinks.org, which is the website through which USAID is communicating everything that we do on climate change. Our goal for this community is to bring together the community of practice working on adaptation here in Washington, D.C. And anybody is welcome to propose a topic and speak in the seminar series. It doesn't have to be a USAID project, and so I'm sure some of you are doing some work that would be very well suited to the seminar series. So please feel free to reach out and propose a talk about something that you're working on, and I'm sure it would be well received by the rest of the community. Next, my talk is happening on October 19th, and it's going to be about the USAID Raleigh project, which stands for Resources to Advance LEAD's Implementation. And they will be talking about their work analyzing climate risks to hydropower and the impacts on energy security. So a very different take on what adaptation means for the energy sector. For today's meeting, I'm very pleased to be able to introduce Fernanda Zermoglio, who's standing at the back of the room. She will be talking today about climate change impacts on the health sector, specifically in Mozambique, and will be introducing just a little bit of what we are doing outside of Mozambique. The origin of this work comes from a few years ago when I and other people working on climate change issues in the Africa region started to be aware that more and more people were bringing up changes that they had seen, that the malaria, where malaria was occurring was changing in Malawi. Where malaria was occurring in other countries like Kenya and Ethiopia was already an easy thing to say. But in Malawi, where the elevation is only around 700 meters, it really struck me as more significant than in the past. And then the most recent IPCC report also tried to evaluate some of the risks to the climate or to various sectors in different regions of the world. And in Africa, they looked quite a bit at the agriculture, water, and health sectors. And it was obvious from that that the health sector had a huge risk from climate change, but also that if we started adapting proactively to climate change, there was the potential for significant reductions in the impacts. And so more and more it became an area that we felt we needed to spend more time on. The health portfolio is one of USAID's largest portfolios. And if the work that we are doing is not going to be sustainable in the face of climate change, we have a major issue. And so we wanted to begin working with a couple of our missions to better understand the risks in the countries in which they operate. And we also started considering what climate change impacts might mean for Africa-wide and how we start making decisions about where we need to focus our efforts and in what area of our health portfolio. So Fernanda has been working with ATLAS for many years, and even before that, she worked with the government of Mozambique to help them better understand the impacts of climate change across a variety of sectors. She has been working on the Mozambique climate change and health work since the get-go, and I'm really looking forward to hearing this talk and hope the rest of you enjoy it as well. Thanks so much.
Thank you, Tegan. Let me just test all of the microphones on me. Testing, 1, 2, 3. Can you hear well? Perfect. That side? We're good to go. It's very likely that they won't be able to hear well as I move around the room, so at least we begin with a clean slate and good sound. Good afternoon, everyone. This is working. It's my pleasure to be here today. I followed the ACMs for many years online from the various different places where I've lived over the last couple of years. And it's a real honor to be able to present to you the work from an amazing and distinguished group of scientists who have put together this research. It's an honor, and it's also a little bit scary because the robustness of this work, I hope, is not. I hope I'm able to communicate it effectively. So if you are listening out there, the researchers in this piece, all errors of omission are mine, but the work speaks for itself. Just a couple of mention of the people that are involved. Chris Heba and Lindsay Allen led the analysis of diarrheal disease. They're from the University of Washington. Anna Steenorn and Chris Jack from the University of Cape Town did most of the climate analysis. James Colburn, formerly of the CDC in Mozambique, did the bulk of the analysis for malaria. And then Mike Swaim supported some of the work that we did on sort of mapping and spatial planning. And last but not least are the three people, Eduardo Samagudo, Colin Quinn, and Tegan Blaine, who have kept it real for us, who have often asked us what the research means in terms of sort of USAID programming and what the government needs to do. So I just wanted to acknowledge that this research is really the culmination of a lot of people's time and effort, and they've been incredibly resilient in the face of a lot of the challenges that come with working in a multidisciplinary team. Okay. So very quickly, what I'd like to do today is just three basic things. The first is to take a step back and paint for you a picture of why we need to work on these issues. What's at stake? How many lives can we save? And what are the opportunities that we have to really try and mediate the negative impacts from climate change on people's lives? Really, health is people's lives. The second is to give you a very summarized view of the study methodology and findings, with an eye towards how it has catalyzed some really significant action in the country, and some really significant changes that I think are very exciting, and we are, as researchers, are very proud to have helped the government and others begin to respond to these risks. And finally, just to let you in on some of our initial thinking on a new piece that we're developing on the hotspots of climate risk in Africa overall. Okay. So we are, within Atlas, mostly looking at the analysis of climate change and how it affects disease in the future. But with this slide, I just want to make the point that for many of the countries where we're working, the issue of climate change and the risk is a problem of the now, right? What this slide shows at the moment is the environmental burden of disease calculated up to 2000 based on 5 endpoints: malaria, diarrheal disease, drought, floods, and one I can never remember. And what you can see very clearly just in using pattern recognition is that the countries that are already the least able to cope with existing risks, countries on the African continent, are the ones that are most at risk from environmental determinants that drive disease patterns. They are also the countries most at risk from a wide range of compounding factors that will negatively impact people and people's health, right? Among this is malnutrition and undernutrition. We know, for example, that people that are undernutrition or children of undernutrition tend to be more susceptible to diarrheal diseases because they can absorb less nutrients. So you have an environmental factor that makes them vulnerable to diseases, and then compounding factors such as hunger and malnutrition that just exacerbate the problem. And it turns out that the research on what is going to happen in the future doesn't necessarily offer a more rosy picture, right? At the bottom of the screen, you'll see projected changes in the number of people in millions that are potentially going to be considered undernutritioned on the African continent by 2050. This just based on our understanding of how crop yields will change by 2050. Doesn't consider other secondary impacts from temperature and rainfall, such as crop losses complete, the reduction in the protein content of crops and micronutrients. So an additional 10 million people are expected to be at risk or are expected to be malnourished under a changing climate. And that obviously has significant implications about the way we program health financing. So specifically in Mozambique, we looked at the association between weather and climate and two diseases, the first of which is diarrheal disease. It's a disease spread through contaminated food and attributable in large part to lack of access to water and sanitation. So some very basic statistics on the stark reality of the disease in Mozambique. 2,500 children a year die in the country from the disease. This is the #2 killer worldwide, and it's totally preventable. We have the tools at our disposal to be able to prevent the disease, or at least treat it effectively. 75% of the people in the country lack access to basic, to toilets, improved sanitation, and access to water, 50%. And it's a major drain on the country's economy in terms of loss of productivity, actual treatment, and all of the other compounding things that come from not having the very basic infrastructure necessary to maintain a healthy population. It's also a climate-sensitive disease because of its natural links to water and sanitation. And this chart just shows you the distribution of incidence, or the number of cases recorded in 1 year's time in Mozambique across different regions. So the color on the bar represents the region on the map. You can see a couple of things that emerge as really interesting. The first is the coastal region tends to have the largest number of cases on a weekly scale. But in terms of the burden for the population, when you adjust it for population, you see that the southern region, I'm going to solidify the laser pointer, the southern region has the greatest burden from the disease. It's a disease that happens year-round, but does have marked seasonal peaks, especially around the hot summer season when the rains are more intense, and less so during the cool winter months. So a clear seasonal signal, a clear regional dynamic, and a clear urgency for the country. As I mentioned before, the research on what's going to happen to this disease in the future is not very promising. What you see on this chart is, again, think of pattern recognition. Don't try to look at the details. For each region in the country, in the world, Southeast Asia, Southern Africa, Equatorial Africa, etc., 3 curves. The first curve is current observed relative risks from diarrheal disease for the population. The second is projected for 2050. And the third is projected by the end of the century. And what you see very clearly is that there are no places in the world where diarrheal disease risk is projected to decrease at all, so under a changing climate. Unfortunately, however, the evidence at a more local and regional scale is lacking. In spite of the high morbidity and mortality caused by the disease, we know very little about what kinds of climate dynamics exacerbate the issue. So this is the subject of the study that I'm going to be presenting. The second disease that we looked at was malaria. Mozambique is one of the top 8 countries in the world where the number of people in malaria die. The highest number of people die of malaria, 15,000 a year. Over 40% of the African population is at risk from the disease. And yet, again, we have tools available at our disposal to address the issue. Those tools are generically, case management, appropriate diagnosis and treatment. They are vector control, indoor residual spraying, and the distribution of bed nets. And in spite of the fact that the President's Malaria Initiative and other donors have spent a significant amount of money in the last 5 years to try and tackle the disease, in some cases control outbreaks, in other cases totally eradicate it, the number of incidences in the country is actually growing. These are actual reported cases of malaria from 2010 to 2014. And again, pattern recognition, red means more cases. And what you see is that from 2010 to 2014, the number of cases is actually increasing. And it's increasing in specific areas as well, right? You see that additional cases are actually emerging in the north. Additional cases in the south of Mozambique, in spite of significant efforts to do that. So the question for us in this research was, we know funds are limited to do vector control and to do case management, but can we use some of this information derived from climate to better target how those limited funds are used? Ooh, there we go. Okay. And unfortunately, as we all know, malaria has a climate signal, and it's due to this pesky little guy, mosquitoes of the genus Anopheles. Why does climate have an association? Well, because this little guy functions better under warmer climates. It bites more, so it has a greater success rate of transmitting the disease. The actual parasite develops faster when it's in hotter temperatures, to a certain extent. There are some caveats, and it survives better under hotter temperatures. So disease prevalence, disease transmission rates, and this prevalence and transmission rates are all related to temperature and rainfall. Now, it's not just the vector, obviously. It's also the human host. People tend to not sleep under bed nets when it's hotter. It's also the parasites. So there are a lot of dynamics that we need to try and understand. And some of the work that we're actually cooking up right now is going to try and address this question. But more to the subject at hand, again, thinking of malaria in the future. What's the message? The zero line is here, or above. Yeah, here, here, and here. Across different regions in Africa under the best and worst case scenario from climate models. What we see clearly is that under any scenario, except for West Africa, the number of people that are projected to be at risk from malaria is going to increase. Does that emerge clearly? And then you look at this bottom left-hand quadrant. And this bottom left-hand quadrant begins to challenge the underlying, some of the research that we think that says that a warmer, sicker climate is all that we'll see. There are actually places in the world, like West Africa, where the temperatures are going to be so hot, not even the mosquito will be able to survive. So there's some good news in West Africa going forward. Not today necessarily. Okay. And finally, this is at the heart of this research. It's applied research. The objective here is to try and offer guidance on the kinds of responses and mechanisms that can be put in place today, acknowledging that the climate system has a memory, that the next 20 years are going to be a result of whatever emissions we've put into the atmosphere now, and that we have to adapt. What this chart shows is from the latest IPCC report is expert judgment. What it says is the following. This is for infectious diseases only. In the present, the risk from climate change to infectious diseases is high. The opportunity to reduce that risk, the lined area, is around 30% of the total risk today. In the near term, and I'll only talk about the near term, the risk, again, high, but the opportunities to reduce that risk, to act now in order to reduce the impact that we will be seeing in the future, is quite significant. It's over 50%. So we have a chance to use some of these data and analytics to try and develop better responses to the risks as they emerge. Okay. So very briefly, I won't read you the questions, but these are the questions that we tried to tackle in this work. What evidence exists that the climate is changing? What role does it play as a factor that mediates health outcomes? And how will this look in the future for the country? This slide is just meant to tell you that this is a multidisciplinary piece of work. It required months of dialogue. We were looking at case incidence data from 17 years for diarrheal disease, what quality of it, really cleaning it up. We were looking at case incidence data for malaria for 5 years. We were working with publicly available climate information, which is for rainfall at the scale of at a monthly time scale, for temperature on a daily time scale. There are a lot of decisions that needed to be made in terms of sort of the methodology, and I'm very happy to discuss that with others afterwards. One key point that I do want to say is that the response of an outbreak happens, or an increase in the number of diseases is normally immediate with temperature changes. But with rainfall changes, there tends to be a lag. And we had to make a choice about what lag times to use. So if it rains today, a big intense rainfall event, how long does it take for a malaria outbreak to happen? And I just want to let you know that we're using a 4-week lag on these data. So very quickly, what are some of the messages around temperature? We know that in the last 30 years, temperatures have risen by 1.5 to 2 degrees. But in the last 10 years, for which we have case incidence data, they've risen much faster. So we can't use the climatological normal. We have to use those 10 years. We know also that they'll continue to rise by 1 degree in the next 20 years. But we also know that hotter days will become more frequent, days above 35 degrees. Cooler nights will become less frequent, days below 25 degrees. And that has implications for vector survival. Okay. Oh, here we go. In terms of rainfall, again, pattern recognition. The top left map on the screen that you see is a comparison of rainfall between 1981 and 1982. Brown means wetter, blue means drier. Every year in sequence until 2014. What this shows is that, well, it's really difficult to say what is a normal annual rainfall pattern in Mozambique, right? Some years are wetter than normal, some years are drier than normal. This is driven by the Southern Oscillation Index, as well as many other factors. So we know that we have to deal with this kind of variability in terms of sort of understanding disease. And this is likely to continue in the future. Nevertheless, just because more water vapor is stored in the atmosphere, we expect that the number of rains that falls in significant rain events that are extreme events are likely to increase. Okay. So the results, very quickly. What we saw in the incidence data, so the historical analysis of incidence with climate, is that as temperatures increase, so does the incidence of diarrheal disease. For every 1 degree temperature increase in a single week, you have an increase in incidence of 1 to 6%, and that varies regional. The coastal region sees the highest increase. In terms of rainfall, remember it's a 4-week lag. What we see is that whenever it rains, 4 weeks later, you have an increase in disease incidence. That's a 1% increase. What that 4 weeks offers is a window of opportunity to respond, right? If we can get enough information, detailed information about when it rained intensively near a health post, we have the capacity to be able to streamline supply chains and get oral rehydration solutions to the places that need it. And then in terms of projections, we see some similar patterns. Higher temperatures, more disease incidence, more rain, a little bit of an increase in disease incidence by region. Okay, and in terms of malaria, the findings suggest some wrinkles in our underlying assumptions, right? The first is, if you have an increase in an extreme event, one extreme rainfall event will lead to an 11% or has led to an 11% decrease in malaria cases. Why is that? Well, logically, the breeding sites can get washed out, and so there's actually an opportunity there for decreased incidence. Nevertheless, if rainfall is normal, or if you have just a normal rainy day, it's likely that you will see an increase of 2% in the incidences of malaria that are observed 4 weeks later. But what the research also shows is that there are some critical thresholds, right? And what this graph shows you is the curve below 25 and 35 degrees appears to be the optimal range of temperatures to allow mosquito survival. That's optimal. As the number of days below 25 degrees decrease, you see a decrease in malaria. So it's hotter. And as the number of days above really, really hot days increases, you see a decrease in malaria. Unfortunately, the signal is the signal is suggesting that these will actually not be as important. These decreases will not be as important as the increases that we expect from a 1 degree increase in temperatures, because that increases the risk. Okay. And then spatially, what does that mean exactly? Well, we see some new areas emerging as being affected by malaria. For example, the northern part of the Zambezi River Basin, the northern part of the Niassa provinces and the mountainous provinces in the north currently have no or very little malaria. And yet those are the provinces likely to be most at risk, or the districts likely to be most at risk. So most health research ends at that point, right? But we had this fantastic opportunity to work with the National Institutes of Health in Mozambique on this work. They provided not only guidance on how this work might be of relevance to the country, but they sit within the Ministry of Health, and so they have the ear of the minister. When a febrile outbreak happens, the minister asks them, is this related to climate? And when we finished the work, the first of its kind debate was launched in Mozambique, a public debate on health and climate change issues, and you'll see that it was opened by two of the country's ministers, the Minister of Health and the Minister of Environment and Rural Development. We know that diseases and the challenges posed by climate change are going to require integrated solutions, and political will opens the door to begin discussions, sharing data across different ministries. So this was actually really important, and there's a lot more that needs to be done. Mozambique also currently has a surveillance system in place for 6 major diseases. It's data collected at the health post scale every week. Unfortunately, it's paper-based. So that surveillance system serves as a historic record of what happens, because it's collected at the health post, compiled at the district post, sent to the region, and then sent to the national headquarters where the database is stored. That process can take anywhere between a month or 6 months. So it is a good surveillance system. But the opportunity exists to change that surveillance system into an epidemic detection system. If you had health post workers sending the data through SMS to a central repository where some of these thresholds that we ourselves have defined can be used to say, hey, Niassa, it has 60 cases more than normal, or 5 cases more than normal. We need to begin to react. The opportunity exists, and some people at the Clinton Global Health Initiative in Mozambique are actually tackling this task with using some of the thresholds that we have defined in this project. Oh, that's that one. And I talked about the wrong one. And then finally, because we were working with an amazing group of researchers in Mozambique, they launched what is called the Climate and Health Observatory in the country as a result of this work, and a lot of the collective thinking that went into designing this piece in the first place. That observatory has signed MOUs with the inordinately always challenging to get challenging partnerships with services like the Met Service. They have MOUs with the Met Service to share data openly and freely so that they can begin to analyze and synthesize that collective information on nutrition, health, and environmental parameters like weather, and to help inform decisions in the ministry. So the Health Observatory is now up and running. Again, a lot more work needs to be done. So I'd like to end with just, I don't know what time it is, but just 3 precursors to some of the thinking that we're developing right now on a new piece of research that we're doing under this task on health and climate change. Now, the maps that I'm going to show you mask an underlying sophisticated set of models that measure mosquito survival rate against temperature using a series of physiologically derived curves that look at characteristics like biting rates, vector competence, parasite development, etc. So there's a lot of complexity behind them, and this is work actually done by Aaron Mordecai and Sadie Ryan, not our own. The first question is, where are the thresholds, the temperature thresholds across the continent where mosquitoes will not survive, and when? What you see here on the screen is exactly that. Areas that are too cold and too hot in a single year across the country, across the continent, by month. You can see a couple of things, right? During the austral winter, it's too cold in the southern part of southern part of Africa for mosquitoes to survive. But they begin to sort of migrate south during the austral summer, December, January, and February. That's the first question: is where are the optimal areas, and how are they distributed on a monthly scale? The second question is, how are these areas changing, or projected to change based on our knowledge of the physiology of the vector? So on the top left-hand side, you'll see the most suitable areas, and the colors represent the number of months for which suitability is optimal. So areas in pink are endemic areas of malaria year-round. Areas in greens and blues are areas that have seasonal malaria. And why is that important? Because your toolbox for addressing malaria is always the same: vector control, case management. But the way you use those tools depends on whether you're looking at controlling outbreaks in endemic malaria year-round, places like Liberia, or really trying to eradicate malaria in places where you have a seasonal signal. So that's the next set of slides. But again, the most suitability, it's actually important to say this is masked. Remember, we're looking at temperature-derived masks. But we need to mask places where it's just too dry for the mosquito to survive. And that's what you see on the screen. And then finally, because we know that those maps just outline the probability that the vector will survive, right? The optimal conditions under which the vector might survive. But we know that transmission is not just dependent on the vector survival, right? It's dependent on a whole host of other factors: socioeconomic factors, urbanization, forest and deforestation, population. All of those things also need to be accounted for if we're going to get a solid picture on where the risks are and where we need to invest. So that's what this work from Sadie Ryan is showing. This is a relative risk of which combines the optimal areas for transmission year-round across the continent, overlaid on top of population density, now on the left-hand side, in the near term, 2020, middle of the century, and at the end of the century. So these are hotspots where the population density is so high and malaria suitability is aligned with that population density where the hotspots emerge. So what we see is actually really interesting, right? The hotspot today sits right along the coast of West Africa. As temperatures begin to rise and the mosquito is pushed away from the West African region, that hotspot in the near term begins to shift towards the central part of Central Africa. Now this is coincidence with population projections. In the middle of the century, it's sitting in East Africa. So one of the questions that we have are, what other kinds of variables do we need to include? For example, variables that evaluate capacity of countries to respond to the risk. Vaccination rates perhaps could be used to try and understand where we might invest current resources and when. So the questions are outlined here, and I won't go into too much detail because it is work that we're still planning. But with that, I will end just by saying that all of the work that is part of part of our project and also part of the health piece is actually found at this site. Thank you. Questions? Yeah, sure. Oh, I'm sorry. There's a whole process in place with a microphone.
Sorry, who was the question? Okay. You can speak into that.
How successful has the Gates Foundation been in eradicating malaria? They put billions of dollars into this. I think there was an attempt to breed the mosquitoes so that they would be sterile, something along those lines, so they don't have to use a spray. And it's the variety of the strain of malaria in Mozambique. Is it the Plasmodium falciparum, which is supposed to be very deadly?
I'll start with the easy question, which is yes, it's Plasmodium parasite-driven malaria, namely, and I'll leave the rest of the question to my friend James to answer. I'm happy to sort of put you in touch with him. On the issue of whether or how successful the Gates Foundation has been, I mean, the truth of the matter is that that toolbox of responses has been around for a long time, right? And there is some fear that the current malaria prophylactics that we're using to treat are that the mosquitoes are becoming resistant, or the Plasmodium is becoming resistant to it. Although there's also some evidence, thanks to the Gates Foundation, that the previous prophylactic that we were using, after 20 years of not using it, could be a substitute treatment under current risks, because there's nothing else in the pipeline. And I think that that's where stands it are. So they're doing some of the basic research required for us to develop new strains of treatments, but it is basic research and it hasn't been rolled out. Our tools are the same as they have been for a long time.
Okay. Hi, my name is Emmett Boyer. I work with the IUCN Global Gender Office. Thank you for being here and telling us about this research. It's very interesting. And I was wondering if there was, during the research process, if there was any consideration to the people who are getting these diseases, sex disaggregated women and men, and then how they will access the preventative resources and the care resources if they are affected by disease.
Yeah, thanks for the question, Emma. Unfortunately, we don't have the data, the incidence data, disaggregated by sex. But we recognize that a couple of things. Children are much more vulnerable to malaria than adults are, simply because they haven't built immunity to it. Women that are pregnant tend to have a reduced immunity, so those are usually the target, the groups that you target in control programs. But unfortunately, we didn't have the data to look at that, unpack that. Although we could, under the hotspots piece, perhaps see how gender might be taken into account. Gender and access to healthcare, distance from healthcare, or the number of people that are served by a single center. There are a couple of ideas, but I'm happy to discuss them.
Thank you very much. I just wanted to ask, is there still a place for mosquito-treated bed nets and indoor spraying in these hotspots that we're talking about? Secondly, I was a bit curious about the range of temperature that you talked about, between 25 and 35 degrees. Now, that seems to me like a normal temperature range for most parts of Africa. So what's making it significantly important that some impacts of increasing malaria? Yet it seems like the normal temperature range for most of Africa, except for the highlands.
Okay, so the first question, just to start at the beginning, was, if you can remind me, I right on the first one. Oh yeah, okay. So again, to amend to the malaria program, there's only those tools available, right? So those responses still are valid and will continue to be valid regardless of the research that we do. It's just that what our hope is that the research will show where to invest the limited resources we have available on those specific things. You mentioned that those are the sort of the normal ranges of temperature for the African continent writ large. yes, on average, but we know that average doesn't exist. We are seeing, just like in the U.S., an increase in the number of days that are really, really hot across Africa, and an increase in the number of nights that are really, really hot in Africa. And nights that are hot means people don't sleep on their bed net, which means that they're more exposed, and especially if you look at another Anopheles genus, which is more active at night, it's very likely that you're increasing your risk profile. That's the first. The second is, again, it's compounded by a lot of other factors, right? If you're malnourished, you're more vulnerable to the disease. And if you're malnourished today because you have lack access to food or your crop failed, it's likely to get worse. So the dynamics of drought and rainfall patterns and how they affect the productivity of the crops that you grow in order to sustain yourself is changing. These are all plausible explanations of a very complex problem. Now, I would wager to say also that recently there was a febrile outbreak in southern Africa, and all of the typical parameters that malaria experts look at, this is a discussion I've had with a malaria expert, so James, forgive me if I say it wrong, all the typical parameters that they look at, like the intensity or effort that is put into different parts of the response pie, let's say, for malaria, they were all pretty much standard. So they couldn't account for the increased incidence in febrile illness from anything other than climate. So it's a challenging topic, but what we're seeing is that these increases are happening in spite of the fact that we're doing the same thing. So it may be related to hotter days, it may be related to colder nights, it may be, hotter nights, and it may be related to a whole host of other factors. I should just say ahead of time that that 25 to 35 degree range is what we tested. Research is showing that that range may actually be a little bit narrower than that, like 26.4 to 28.4 is optimal. So that's something to be explored. And in the hotspots work, what I didn't mention is that we're also working on other vector-borne diseases like the mosquitoes that carry dengue and chikungunya and Zika.
We'll take one more in the room, and then there's one online we'll take as well.
Thank you so much for a really great presentation. I wanted to go back to that graph that showed that in the near term we had an increase, it looked like an increased opportunity to reduce risk. And I was wondering if you could touch a little bit on what were those opportunities there, or why is our, why is our opportunity increasing in this near-term window?
Right. But it's just, perhaps an analogy is appropriate. We know that the things that we're doing today are to the atmosphere are going to trickle in terms of effects. So increased intensity of storms, hotter temperatures. They're going to be slow to come, but they're coming, right? And they're slow. So the atmosphere manifests those changes in complex ways. The problem is that if we keep our head in the ground and wait until those changes are observed, we have very little time to try and adapt what needs to be done. But if we start today thinking about, for example, improving the protein content in short cycle varieties that we're distributing across Africa so that we guarantee micronutrients and food quality availability, today it's a research question. And that research question needs to be put in place today in order to have a response in 5 years, in 2 years, in 6 years, in order to deal with what is going to happen regardless of our response in terms of mitigation today. So if we don't do anything, the business as usual scenario says we're just going to be more at risk. If we start to react, then it's very likely that we'll have an opportunity to reduce that risk. It's the sort of the typical frog in the boiling water scenario. You know, you don't jump out until it's too late, right? The frog doesn't know that it needs to change. Same thing with our work in the health sector. We need to begin to address the issues of climate today, because some of them require research, some of them require radical changes in the way we do things. And research we don't have yet, and it takes time to build the evidence base in order to change those responses. So.
Okay, just a question and a comment online from Eric Heim, and the comment is that it's really important presentation to disseminate to donor agency senior managers. And the question is, the malaria incidence maps showed large increases over a short number of years. Has this data been related back to temperature and precipitation changes in those years? Might improved access to medical services diagnosing malaria also have affected the reported incidence over that time period?
Thanks, Eric. I guess the short answer is this: are there other factors other than climate that are impacting the number of cases that we see? The short answer is yes, but we did try to account for it in some way. So, for example, I think the malaria record that we initially had was 9 or 10 years, and we only used the last 10 years for which a different kind of sort of mechanism for diagnosis had emerged in the country. So yes, there are other issues that are probably compounding this, and certainly we don't sort of intend to say that the climate is the only driver of disease incidence. There are a lot of other things: population migration, movement, et cetera, that are exacerbating the problem. So, good question and good point to make.
We have a few more minutes if there's any more questions. Otherwise, we can wrap up.
This is just sort of speculative, I guess, but I thought it was really interesting to think about how not only are increasing temperatures driving incidence of malaria, but then they're also driving behavior change, which further increases malaria in terms of the specific example of not sleeping under bed nets when it's really hot. And I'm wondering if you're finding any other, or if you're speculating about any other of those types of interesting relationships where the climate change is indirectly driving behaviors that may affect malaria incidence. I mean, that's a very clear and interesting one, but I bet there's other ones out there too that might be interesting. Maybe not quite as dramatic as that one.
Yeah, well, I mean, there's anecdotal evidence, right? At least evidence I've heard of, where the mosquito that transmits Zika, chikungunya, and dengue is the Aedes mosquito, which incidentally was just discovered in Toronto. It's a tropical mosquito. It tends to bite pretty much any time of the day and night, so it's very active all the time. And so you can imagine that people we're altering our work cycle based on heat stress, right? A lot of people are working at night instead of the day. But if you are exposed to this mosquito, you're likely to, the exposure element is increasing. So there's some interesting sort of dynamics around how if we alter our working cycle, you might actually increase your exposure to the vectors that are driving disease. But again, just insights, not necessarily, well, I guess it's science, but it's not my science. So I'm trying to present that as well as I can. Great. Well, thank you. I appreciate you guys being here at Rosh Hashanah, during Rosh Hashanah.
And I would like to just say one more thing. For those of you who haven't seen some of the papers that we have outside, one of the first products that we developed as part of our work on climate change and health is a update of what the IPCC reports have published, and trying to make that work a bit more digestible for a development-oriented audience. So it's an update of the research covered in the last IPCC report, translated into English as much as possible. And so you can find that out there. We also have already published some of this, a summary of this early work on Mozambique. The full report is forthcoming sometime soon. And all of those reports, as well as some infographics, as well as some work that we did in Senegal early on, are all available on climatelinks.org. And that's where we will be publishing all additional work as well. So feel free to go to Climate Links to get versions of those. Thanks so much.